Hi, everyone. Good afternoon. Thank you for joining us on International Women's Day. I guess I should say Happy International Women's Day, although that feels like a bit of a stretch. Okay, anyway, but thank you for joining us and thank you for your continuous work in support of the NYCLU, the ACLU, and the fight for reproductive justice. Special thanks to our longtime event sponsor, Davis Wright and Tremaine. We thought it was important to connect with you, our supporters and friends, to talk about the attacks on women's rights, the frightening landscape of abortion access across the country, our political and legal strategies, and to answer questions about the current state of Roe v. Wade and the future of reproductive rights, health, and justice in the United States. Today, we face an existential threat to reproductive freedom. Women across the country, especially those most marginalized, are already unable to exercise their right to get an abortion. And the situation could and most likely will get worse, much worse, soon. In this call, we'll talk frankly about the situation, what we need to do short-term and long-term to make sure that we protect access as much as humanly possible and continue the fight for reproductive rights and justice, including ensuring that New York is a place that people can go to get abortion care. Thank you, everybody on the panel today. It's good to see you all. And I really am glad that our whole crew gets to see you and hear from you today. Whether you're an ACLU or NYCLU supporter, staff member, board member, partner, or leader in the field of reproductive health, delivering essential services and ensuring protection and access for all, thank you, thank you, thank you for joining with us today and in the ongoing struggle for justice. Now I am thrilled, I really am thrilled to pass the mic along to Terry Mcgovern, who is a friend, colleague for decades, and fabulous leader in the fight for reproductive health and justice, who's going to moderate this event and introduce our speakers. Terry is a member, among other things, of the NYCLU board. She's a professor and chair of the Halbrun Department of Population and Family Health at Columbia University Mailman School of Public Health. That is a mouthful, but you know, Terry is even bigger than that mouthful. Her research focuses on health and human rights, sexual and reproductive rights, and health, gender justice, and environmental justice. So Terry, you're on.
Thank you, Donna. Thank you, Donna, for the introduction. I am so proud to be an NYCLU board member and supporter. Working together with Donna and the NYCLU and the ACLU staff to protect reproductive rights and gender justice. And we couldn't do it without our advocacy and provider partners like Planned Parenthood. My work is devoted to gender justice and reproductive rights in the US and globally. I do this work because early in my career as a poverty lawyer working with HIV positive folks, I saw that structural racism and sexism conspired to kill my clients, or at the very least deny them bodily autonomy, the right to life and justice. It's taken generations of activists, organizers, and communities fighting for reproductive freedoms and gender justice to get us where we are today. And even the wins we have seen have never ensured access or reproductive justice for the many vulnerable groups and people around the country. Today, all of the victories for reproductive justice we have seen in the past decades are under threat. That's why this conversation is so important. Today, you will hear about how the Supreme Court is attacking our rights in the most hypocritical and cynical fashion. During oral arguments for Dobbs v. Jackson by the Supreme Court, we heard Justice Amy Coney Barrett state that Roe could be overturned without burden to women, girls, or pregnant people. Yes, there's an intrusion on the body, but we have that with vaccines. Anyway, they can just carry to term. We terminate their parental rights within 48 hours, and safe haven laws take care of the newborns. This is what our justice said. She repeatedly raised safe haven laws as an alternative to abortion during the argument. Safe haven laws were first adopted in Texas in 1999 and have expanded to all 50 states and Puerto Rico. They are unregulated. These laws allow for continued criminalization of mothers who surrender their infants and a failure to maintain confidentiality, among many other problems. While research on the impact of safe haven laws is limited, there is considerable evidence that the child welfare system that these laws operate within has a long history of abuse, neglect, and racism. Mississippi and Texas, both states with horrific health outcomes for women and children, have some of the worst records of endangering children placed in these systems. We need to understand that these are extremely problematic statements being made by our highest court, statements that will lead to ongoing, continued human rights abuses, racial disparities, and harm to women, children, and pregnant people. Shame on SCOTUS. Our panel today is made up of top policy, legal, health, and advocacy experts in the reproductive health field. The bios of the speakers were included in your RSVP confirmation and are on the event page, which is linked in the chat. So I'm not going to introduce anybody in too much detail. But first, we'll hear from Brigitte Amiri, who is the Deputy Director at the ACLU and who has litigated reproductive rights cases with the ACLU Reproductive Freedom Project. They obviously have not had a moment's rest in the past few years, and we are extremely grateful to them. After that, we'll hear from Stacey Fox, who serves as President and Chief Executive Officer for Planned Parenthood Southeast and Planned Parenthood Southeast Advocates. She focuses on advancing and making way for the next generation of leaders fighting to protect reproductive rights and expand access to compassionate, non-judgmental health care. After Stacey, we hear from Dr. Mira Shah, who is an abortion provider and family medicine physician, currently serving as the Chief Medical Officer of Planned Parenthood Hudson-Peconic in New York. She'll share her stories and experiences as a provider in New York and as she is transitioning to working with Whole Women's Health in Indiana. Next, we'll hear from Catherine Bodie, NYCLU's Assistant Policy Director, who will tell us about the legislative and policy scene in New York, including our advocacy for the Equality Amendment. Finally, we will have Gabriela Larios, an Equal Justice Works Fellow who engages in policy advocacy and litigation for reproductive health care. She'll speak on the New York landscape and how the NYCLU is working to make New York an access state for abortion care. We'll end with question and answer session. Please do submit your questions through the question and answer function. We'll also cover those submitted in advance. With that, I'll turn it over to Brigitte.
Hi, everyone, and thank you so much for having me, and thank you for joining us today. My name is Brigitte Amiri, and I use she, her pronouns, and I am the Deputy Director at the ACLU's Reproductive Freedom Project. And we are at a very dire moment in abortion rights in this country right now, as folks have already talked about. The case that we all know is coming down the pike is Dobbs versus Jackson Women's Health. It's a case out of Mississippi about a 15-week abortion ban and whether that ban is unconstitutional. But the question accepted by the Supreme Court is whether all pre-viability bans are constitutional. That's a huge question. And as Terry already alluded, their questions were far-ranging by the justices at oral argument. The case is brought by our good friends at the Center for Reproductive Rights. And obviously the impact of the decision will not just be limited to Mississippi, but will have a wide range of effects on the country overall. The decision is expected probably at the end of June, and there are different scenarios in terms of what the court could do. The worst case scenario is that the court could overturn Roe versus Wade completely. And in that situation, about half the states in this country will ban abortion. And that will obviously have devastating consequences, as Terry already talked about, for the most marginalized in this country. Right now, it's as if Roe versus Wade wasn't decided for many people in this country, people with the fewest resources, people with who live in rural areas, young people, people who lack documentation for their immigration status. And those burdens will just be compounded in states that have banned abortion because they will be unable to leave their state to get care. And that is really the worst case scenario. And every time I say this, it just feels unreal. It feels unreal that in my lifetime, that we would actually see a situation where the constitutional right to abortion is lost. So we are obviously hoping that that worst case scenario does not happen. If that doesn't happen, however, I fear that perhaps the best case scenario is that the Supreme Court says that states may ban abortions at 15 weeks in pregnancy. And I think that all of those half of states that would overturn, that if Roe was overturned, would ban abortion, would also ban abortion at 15 weeks. So this is also another reason, as Terry mentioned, that for states like New York and other states where abortion access is going to be available, that it is available as much as possible. So all of the policy work that the NYCLU has done in coalition in New York has been so critical, because in states like New York and in other states across the country where abortion access is going to be available, that as a haven state, it's going to be so important that there are as few barriers as possible for when people need to come, assuming that they can travel out of their state to get care. We've always known that Roe is the floor and not the ceiling, as I mentioned before. For so many people in this country, it's as if Roe wasn't ever decided. There has been a long campaign of the other side chipping away at the right, pushing abortion out of reach until they got emboldened by a series of political factors that really allowed them to push forward abortion bans and got us to the place where we are today. So we know that they won't stop at overturning Roe. So we talk about the states that will ban abortions and the states that will allow abortions, but we're also going to see the next level of restrictions if Roe is overturned. We're going to see that states will try to prohibit people from leaving their home state to try to get abortions in other states. And we're also going to see the other side push for a national ban on abortion. So as we are rebuilding the right to abortion and always trying to restore access and expand access, we are also going to have the 50-year plan and keep our eyes on the prize of the defensive work of trying to prevent that from happening, and also trying to push forward our progressive policies to make sure that everyone can get access to abortion regardless of where they live and regardless of how much money they make. And to do this, we're going to need all the tools in the toolbox. So we've already talked about the fabulous state policy work that is going on in states like New York. That is obviously going to continue. We are going to be relying on state constitutions and state courts. And right now, we're also pushing measures at the federal level as well. So the Women's Health Protection Act would go a long way to ensuring access to abortion. And as folks may have seen in the news, it has passed the House and it fell a few votes short of passing in the Senate. But the pressure has to stay on. The pressure has to stay on Congress and the federal government in this particular moment to do everything they can to protect access to abortion and really lay the groundwork for the support that's needed. The public is on our side. People want abortion access. And because of all of the different ways that the vote is diluted, the gerrymandering systems that we have in this country, people's voices don't translate into that policy. And so we need to encourage everyone to speak up, call their representatives at the local, state, and federal level to make sure that, that we can not only try to preserve access, but expand access and keep our eye on that prize for that long-term goal of ensuring that everybody is able to get the care that they need. So I think I will stop there and turn it over to Stacey.
Thanks, Brigitte. So good to be with you today and finally get to meet you in person via video after years and years of working together. I'm really honored to be here today. As Terry said, my name is Stacey Fox. I use she, her pronouns, and I'm the Planned Parenthood Southeast President and CEO. And before I start, I just want to take a couple of seconds to make space for all the individual humans and family systems that are suffering in the Ukraine or have fled from the Ukraine. And also, I happen to be in Florida today, and it's a sad day in Florida. And I just want to lift up all our LGBTQIA friends and loved ones as the state the Senate has passed a really hateful bill out of the Senate that's headed to the governor in Florida today. So I hope y'all keep all those folks in your hearts. As you heard, and as y'all know, abortion is already hard to access. This is not new news, and it's just about to get harder. Planned Parenthood Southeast works across Georgia, Alabama, and Mississippi. And you probably think, whoa, if you're from New York, that's a lot. And it is a lot. It's a very different landscape here in the South than it happens to be in New York. And just to set the tone for you, before we even hear from the Supreme Court, here in our 3 states, people who can get pregnant and want to access abortion are required to go through mandatory counseling. They're required to have waiting periods because we don't trust them to make their own decisions. They often have to visit a clinic twice, if not 3 times. They are required to hear certain mandated counseling that is not evidence or science-based from the state. On top of issues like security for staff, we work and live in areas where people have died because of their fight for access to safe and legal abortion here in the South. And recruiting providers to come to the South to provide care is hard for all of those reasons. And fast forward to a potential decision from the Supreme Court that we are all waiting on. In states like Alabama and Mississippi, there are constitutional amendments on the books. These are 2 states out of almost up to 26 states that could lose access because those states have already drawn the line in the sand if Roe were to be overturned. In Georgia, we have a 6-week ban that's currently on hold in the courts, waiting for the Supreme Court to make its decision. So abortion could also be really inaccessible in the state of Georgia, not completely, but almost, after we hear from the Supreme Court. And we're talking about states that you probably can imagine these things are true, but just to remind you about what health disparities look like in the South. And let me just start by talking about the state of Mississippi, who argues in the Dobbs v. Jackson women's case, the state of Mississippi argues that there's no need to protect access to abortion anymore because we've made so many advances in the space of gender equality. A state that does not even have an equal law pay on the books still. A state that just a couple of years ago took the Confederate flag off its state flag. A state where HIV rates are shooting through the roof. And you move east to Alabama, where Black women are dying 3 times the rate of their white sisters from cervical cancer. And in Georgia, over half of the counties in the state do not even have an OBGYN. And people want to be pregnant are dying and don't have to be. These are the health disparities that we're already dealing with and that these states aren't addressing, much less having not ever expanded Medicaid. So it feels a little bleak. But I will tell you, despite a pandemic, despite the fight, our doors stay open in the South. We haven't closed our doors. We're continuing to provide care, and we will do that every day. And thank goodness for partners like the ACLU who lock arms with us and go to court with us all over the country to help make sure our doors stay open. I also want you to know that, we're all tracking what's happening out of Texas because of SB 8 and using that to inform us about what we need to do in the future. Because one of the things we're learning out of Texas is that we don't know if, when, or how someone who wants to seek an abortion is going to travel. The closest state may be New Mexico, but the easiest state for that patient may be something like New York. because an aunt lives there, or it's cheaper to get there, or easier for them to get there. So we all have to be prepared. And I would want y'all to know that while you sit in New York and your partners are working to prepare for expanding access to care, we are planning here in the South for preparing to help our patients navigate this new system. In fact, at Planned Parenthood Southeast, we've just hired a patient navigator to prepare to do just that, to take care of these patients holistically, their travel needs, their healthcare needs, their childcare needs, financial needs, because we're talking about whole people here. And we're doing this in partnership with people all over the country. I think a lot of people ask, what can you do? I don't want anybody to leave in a doom and gloom space today. What you can do are a few things I would share. I love talking about a stagnated note in music where, you know, a musician or a vocalist, there's a number of people holding that note. And when someone takes a breath, another person's holding the note. So if you're holding the note, make sure you're making space for the person who's taking a breath. And if you need to take a breath, take it, because there are other people standing in your space. But take care of yourself. If you can't show up here, we can't continue this work. I'd also say support abortion funds. They're going to help these patients on the front lines. We need to get really comfortable talking about self-managed care. And finally, if you don't know, 1 in 4 people who can get pregnant are going to have an abortion at some point in their life, or already have. And if you feel comfortable and safe, you need to share your story. I know when I was a freshman in college, I had an abortion. I drove to Atlanta by myself, and I drove back to Athens and went back to class the next day. And I'm so glad that I had that care. And I'm able to tell that story because of amazing providers like Dr. Mira Shah, who's a colleague at Planned Parenthood. And I'm going to hand the mic over to her.
Thank you so much, Stacey. That was wonderful. And it was so good to hear from you, and your energy is really palpable, and I appreciate that. It's really what I needed today. Thank you so much to NYCLU for inviting me to participate in this panel. Abortion access is very near and dear to me, and I have really dedicated my career to ensuring that my patients have access. I am the Chief Medical Officer of Planned Parenthood Hudson-Peconic, so I oversee 10 health centers in Suffolk County, which is in Long Island, Westchester, and Rockland County. I also, as of yesterday, am the medical director of Whole Women's Health Alliance in South Bend. So I wear a lot of hats, but those 2 roles are where I dedicate the most of my time and energy. When I became a physician, I took an oath, and I took an oath to first do no harm and to care for my patients, regardless of their race, their ethnicity, their ability to pay, any hardships that they may face. I took an oath to ensure that I was doing everything in my power and in my ability to make sure that they received care. Unfortunately, with abortion access, I have a really hard time doing that. And so I just wanted to take a few moments to describe sort of what it's like for me to provide abortion care in New York, as opposed to providing abortion care in Indiana. So in New York, a patient can call us in the morning, having just taken a pregnancy test at home and deciding that they want an abortion, and come to us that same day for an abortion. New York Medicaid covers, it's one of the few states, one of the 17 states that allows for folks with Medicaid to pay for their abortion. And the vast majority of the patients that I see are low income, uninsured, underinsured, or Medicaid carrying. And so this is huge. What New York has recognized is that abortion care is healthcare. It's a human right, and therefore it should be covered regardless of the type of insurance that an individual has. That said, if a patient is truly uninsured, then we tap into our friends at our closest abortion fund, who have been incredible in making sure that our abortions get some support around the cost of their abortion. So I second what Stacey said, and if you want to donate, please donate to an abortion fund, because I've seen firsthand where this money goes and how it can help people. So going back to what it looks like to provide abortion care. So the patient comes in, let's say they want a medication abortion. They, we figure out how far along they are in their pregnancy, and then we provide them with the pills. Alternatively, we can provide telemedicine abortion. And in Indiana, this looks very different. So I've been flying to Indiana once a month to provide abortion care for the past 5 years. And we actually were only providing medication abortion. It took a lot of effort on Whole Women's Health Alliance's part to get the clinic open, to get all the permits, because as you can imagine, in a conservative and a red state, the state made it incredibly difficult to allow for any of that to happen smoothly. And so there were a lot of hurdles, but they were worth it, because in the end, we were able to open the health center and provide at least medication abortion. That said, there's a shortage of abortion providers around the country. I spend a lot of my time at Planned Parenthood in New York training abortion providers. I always tell my staff and my doctors, we never have a day of abortion procedures without a trainee, because we need to do everything that we can to train as many doctors as possible, many providers as possible, to ensure access. So in Indiana, there aren't very many providers, which is why I was flying. And the majority of the providers actually come from out of state to provide care. We have to do an ultrasound. It's mandatory. We have to read a script, similar to what Stacey was describing. In the script, it says that life begins at conception, that abortion has been related to mood symptoms, PTSD. Most of what's in this script is not evidence-based or rooted in science, but unfortunately we have to say that because we have to follow all the laws. The patient then has to come back 18 hours later to be handed the abortion pills by a physician. So a nurse practitioner can do the ultrasound and do the counseling, but the person who actually hands the pills has to be a physician. When I know in my practice in New York, nurse practitioners, PAs, and midwives can provide the provision of abortion care because they are competent, they're trained. But in Indiana, there's all these rules in place to, again, prevent access. Patients aren't allowed to use their insurance. They have to pay out of pocket. And there's a telemedication abortion ban. We cannot provide the provision of medication abortion through a telemedicine platform. It's totally against the law. So I worry for my health center in South Bend. We've worked so hard to open it, to see our patients, to care for our patients. And we actually just got permission to provide procedural abortion up to 13 weeks and 6 days. And I'm terrified that this summer, all of that may change. That said, we're continuing to fight. We're continuing to, keep our doors open and care for whoever we can, given what's currently allowed and what's unfortunately, may be our fate in that we may have to close. And so our work hasn't ended here. Like I said, I provide full spectrum sexual reproductive health care, from vasectomies, prenatal care, abortion care in New York. And I provide the provision of abortion care only in Indiana, but a large part of my job is not only patient care, but it is advocating for my patients. It's almost my ethical duty, and I will continue to do so. And thank you to ACLU and to NYCLU for putting up the fight and for bringing me along, because I'm here for it. And I would like to introduce my colleague, Catherine from Aclu, to continue the conversation.
Thank you so much, Dr. Shah. It is always such a pleasure to hear you speak. Hello, everybody. My name is Catherine Bodie, she, her pronouns. I'm with the NYCLU. And I want to start off just by saying how grateful I am to have the opportunity that we can all gather here on International Women's Day to mark the anniversary of Roe v. Wade, in particular this year for all of the reasons that we've been discussing. It feels really important to continue to gather in community to really understand the moment that we're in and how we can best position ourselves to it. And so I just want to say a huge shout out to our NYCLU team for creating this space, to our amazing speakers for bringing your expertise to the table, and for all of you for taking the time to be present today with this information. My role here today is really to focus us in on New York, what we've done, what we're doing, and the work that lies ahead. And so to do so, I think I want to spend a moment really grounding us in the current moment in order for us to understand the importance of states like New York stepping up. You know, as our previous speakers have made so clear, the outlook is dire. With a 6-3 decidedly anti-abortion Supreme Court, the federal constitutional right to abortion is really hanging by a thread. And at the same time, we're seeing the continuation of trends that began decades ago in other states and have only accelerated. So in this moment, if you are a supporter of gender justice, of trusting women, of reproductive rights, health, justice, this can really feel like a moment of grief and despair. You know, when Justice Ginsburg died, it was a total blow for so many reasons. The loss of Ginsburg was the loss of a person who opened up doors for so many of us. And it was devastating to know that her replacement would close those same doors and would really be the seal on a conservative court that is shifting our legal system and our democracy in fundamental ways that undermine the necessary work that this country needs to do in order to heal our past. And so when Justice Ginsburg died, I will never forget actually what one of our ACLU colleagues said. And she was in part quoting or taking this from the abolitionist organizer Miriam Kaba. But she said that hope is a discipline, and that revolutions are born out of our grief and out of our despair. And what that means for me really is that our grief can illuminate our call to action. And I'm not counseling that we organize around our pain. Indeed, I think that we really need to start organizing around our values of connection and community and healing and equality and justice and support, and really caring deeply about each other. And so here we are in this moment together with our work really cut out for us. And it will be critical for states like New York to step up, to fight back, to protect abortion rights, and to advance access really wherever we can. And New York has made important strides. In 2019, we stepped up big. It was that year that we passed a law called the Reproductive Health Act, and that was a major victory. The RHA decriminalized abortion in New York State and put affirmative protections in our public health law. And that was really so important for New Yorkers, certainly, but also those who would seek care within our borders. New York has a history of opening its doors. When we partially decriminalized abortion in 1970, 3 years before Roe, people came from all over the US. They really came from all over the world to access care here. We had billboards on our borders saying, if you need an abortion, come here. And that message hasn't changed. If you need an abortion, you can come here. So we are preparing to ensure that New York lives up to that New York is really an access state. And there is a lot of work happening, and certainly much work that is we still need to do. And when I think about our work really falls into several buckets, including our work in community that my colleague Gabby is going to unpack a bit in a moment, and our work with providers such as Dr. Shaw to really understand the access landscape and expand access to care. But for my last few moments here, I really want to touch upon our policy work, and in particular, one of our policy priorities for this year. And that is passing an equality amendment in New York State. The New York State Constitution does not clearly contain independent protections for pregnant people. And in particular, their ability to make decisions about their pregnancies, their health, their lives, and their future. And so it feels really absolutely critical that we pass an equality amendment in New York to make sure that our founding document reflects our values, protects our people, and so that we can also really step into a leadership role for the rest of the country. And importantly, the proposal rightfully situates these protections in a really broad equality framework that amends our state constitution to add critical anti-discrimination protections that advance racial justice, that advance disability justice, immigrants' rights, along with our LGBT community as well. And the pregnancy protections within the proposal also situate abortion protections within a broader framework of all pregnancy outcomes. And that's important so that we as a movement can acknowledge and can honor and can protect the various ways in which pregnant people are targeted and punished and prosecuted in this country and in our state. And there is an equality amendment that has been put forward by Senator Krueger. And as I mentioned, it is really critical that this get done this year, but also that our representatives hear how important it is to do this session. Constitutional amendments require passage in 2 separate legislative sessions before going to the ballot. And so if we want this on a ballot in 2024, then we need to have the legislature vote on this before the end of session at the beginning of June. And beyond working to pass an equality amendment, our policy agenda contains several other priorities as well. And I will just touch on a few to end here. But we are working to include a provision that we hope will go in the state budget this year that would expand insurance coverage for abortion. We are working on a measure that would create a tax contribution fund to supplement those who need to travel for out of state or those who otherwise fall through the cracks in our coverage scheme. We're working on a bill that would require informed consent to drug test a pregnant person so that we can avoid harmful and unnecessary family separation. And I also just want to mention a bill that we're working on that would also expand post-pregnancy Medicaid coverage to 1 year, which is a really critical measure to reducing maternal mortality. And with that, I'm going to hand it over to my amazing colleague, Gabby, to talk about her work in community to expand access to healthcare. Thanks, everyone.
Thanks, Catherine. It is such an honor to be your colleague and to work alongside you and to be here with everyone today. So again, my name is Gabby Ladios, she, her pronouns, and I'm an Equal Justice Works Fellow here at the NYCLU. And before I dive into what's happening on the ground in New York, I want to paint a bigger picture of how religion is being used to discriminate in the reproductive freedom sphere across the country. So in the courts, we're seeing, as Catherine was talking about, huge doctrinal shifts and attempts to massively expand religious exemptions in the scope of the First Amendment. So for background, religious exemptions are claims by individuals and institutions that they be treated differently than everyone else. And these claims are often requests for a special license to discriminate against some people because of their religious beliefs. And at the ACLU, religious liberty is obviously core to the Constitution and needs to be protected, but these claims for religious exemptions can't inflict harm on third parties. We see this pop up in a number of different ways. One of the most prominent examples is Hobby Lobby, a Supreme Court case from 2014, where for the first time, the court allowed a closely held for-profit corporation to deny its employees access to basic healthcare like birth control because of religious beliefs. Just last month, we submitted a friend of the court brief here in New York in a challenge to New York's insurance abortion coverage requirement by religious employers who are trying to expand the scope of the federal Constitution and overturn New York precedent. And this isn't a new issue. We've seen claims for religious exemptions to allow racial discrimination and are seeing more and more of these claims to allow sexual orientation discrimination. The only difference now is that the tide is turning and the courts appear more willing to make these accommodations and changes to expand the ability of religion to be used to discriminate. So while high-profile legislative restrictions to abortion in states like Texas and Indiana are rightfully getting full public attention, other threats to reproductive health care can often fly under the radar and go unnoticed. So hospital mergers are crafted and approved behind closed doors, but these transactions tend to have severe impacts on access, especially in states like California, Washington, and New York, where support for abortion is high. And for background, a hospital merger or hospital consolidation is usually when one big hospital Pac-Mans up a smaller failing hospital and absorbs it into a larger healthcare system. But whatever you call it, it's clear that religion's role in providing healthcare has expanded dramatically. This hospital consolidation has led to an increasing number of religiously affiliated hospitals that follow ethical and religious directives that prohibit some kinds of medical care like abortions, treatment of ectopic pregnancies, miscarriage management, sterilization, and fertility treatments. And today, 1 in 6 hospital patients is actually treated at a Catholic facility that follows directives like these. So these hospital systems have expanded rapidly, especially over the past 15 years, and their interference with the doctor-patient relationship presents a real threat to access to reproductive health care. So in Catholic hospitals, abortions are completely prohibited by the ethical and religious directives, which I'll refer to as the ERDs. And this means that somebody who's seeking care for a miscarriage at a Catholic hospital could also face restricted care because doctors have to test for a fetal heartbeat, even when a miscarriage is clearly inevitable. And if the heartbeat is detectable, they have to wait for signs of an infection before treating it. And to be clear, this isn't the standard practice in non-religious settings where OBGYN care is more patient-centered and miscarriage management is offered to reduce pain and risk to a person's life and health. And in our work, we've heard stories about a hospital in New York with a policy against treating miscarriages so long as there's a fetal heartbeat. So patients who miscarry languish without care as a result, sometimes going into sepsis, which is a life-threatening medical emergency. And their only hope is that a sympathetic provider on staff that day will transfer them to a hospital that doesn't have these policies. While most abortions aren't performed in a hospital setting, the ones that are often the most serious and complicated abortions, including those performed because a person's life or health is in danger or in the later stages of pregnancy. But it's not just abortion. The ERDs also classify sterilization procedures as intrinsically immoral. This means that tubal ligations, which are safest immediately after C-section, are also prohibited, which means patients have to get a second subsequent surgery elsewhere. And this presents itself as sex discrimination because this has a really big disparate impact on people who have the capacity to become pregnant. So medical providers respond to these restrictions by transferring patients out, falsifying charts, or misdiagnosing to work around the restrictions, or delaying or denying care. So birth control is prescribed for heavy bleeding instead of for contraception. Tubal ligations are performed for cancer prevention instead of contraception. And in New York, we're on the ground in Schenectady, New York, to fight a proposed merger between Ellis Medicine, a secular hospital, and St. Peter's, a Catholic hospital that's part of Trinity Health, which is an even larger hospital system based out of Michigan. And we're collaborating closely with our regional office in the Capital Region, who has been really key here in strengthening our relationships and providing local expertise. We're part of the Schenectady Coalition for Healthcare Access, which was formed back in October 2020 when this merger was first announced. And it was founded with the goal of maintaining access to reproductive care, LGBTQ care, and end-of-life care, and to ensure that evidence-based medical care is locally accessible. Schenectady County is really in need of a thriving community hospital, but they need a community hospital that will serve all members of the community and put patients first. And the community in the capital region has real big reason to be skeptical of consolidation and broken promises. In Troy, which is about 30 minutes from Schenectady, we had the first hospital within a hospital. So there was the Brigitte Birth Center, which was carved out within a Catholic facility and was able to provide sterilization, birth control, and treatment of certain pregnancy emergencies. But Brigitte collapsed, and it's now been folded back into the Catholic facility. So we see that even when there are carve-outs and even when there are attempts to preserve some kinds of care, it often fails. And I think we often see abortion exceptionalism, where only abortion is prohibited, and that's what we saw there too. Ellis has Bellevue, which is the capital region's leading maternity hospital. So if the ERDs were to take effect there, it would have severe consequences for access to care there. The nearest non-religious hospital to Schenectady is Albany Med, but to get there, you need to take 3 buses. And it's just simply not a solution for the community. So Schenectady County residents have really shown up, attending rallies, community forums, public comments, all of the things. And we've already seen some wins because of this robust community engagement. We've been able to slow down a full merger and are poised to keep our eyes and ears on the ground and show how detrimental a full merger would be. And finally, we're working on some legislative fixes here. We're working to pass a hospital transparency bill that would help identify where particular kinds of care are unavailable because of things like religious restrictions. And this would help us identify key service areas that where entire regions are unable to access care. So in Schenectady and beyond, Aclu is going to continue this fight alongside patients, caregivers, doctors, nurses, and clergy to ensure that life-saving, evidence-based reproductive care will not be in jeopardy in New York or elsewhere. Thanks.
Okay, thank you all. Thank you all for your commitment, your passion, your creativity, and the point about us all being in community is not lost. One question that I think people have all the time, which if you don't mind, you can all illuminate the answer, why medication abortion won't solve this problem of Roe being overturned. Can some of you talk a bit about some of what you already mentioned, how the right wing is responding to medication abortion? Anyone?
Sure, I'll start and other folks can chime in. I mean,
Thank you.
the legal landscape, I mean, so the hostile states have already restricted telehealth abortions. In Kentucky, for example, the doctor, and as Dr. Shaw was mentioning, in Indiana, the doctor, and it has to be a doctor, give the pills to the patient. So that is the state of the law in many hostile situations. So anyone who would be providing pills to patients, people in these hostile states, would be operating outside of the confines of the law, and so that with sometimes with criminal penalties. And I think some folks have already talked about the disproportionate impact on criminalization of self-managed abortion on people of color in particular. So I'll let others draw on that, but that's the challenge.
Thank you.
I would also just jump in and say that medication abortion, while it may seem easy to access for a patient, there are a lot of patients that don't live in comfortable or safe environments where they could go home and experience abortion via medication abortion. So there's a much broader impact here. It's certainly not a quick fix. And I think, Terry, you were alluding to the fact that, and Brigitte, you too, that's just sort of eroding at access, depending on what happens with SCOTUS this year. We're going to see attacks coming left and right so that they're shutting everything down. I know Georgia's got a bill moving right now about medication abortion related to the REMS restriction lifting. So, it's just an onslaught.
I can also add that, not everybody is eligible for a medication abortion. I mean, the vast majority of abortion occurs in the first trimester, but some people are pregnant beyond that gestation age. They also have while there are very few medical complications to a medication abortion, there are still a few that exist. And, there's certain scenarios in which I would never recommend that a patient have a medication abortion, and that the only safe method for them is a procedural abortion. So, that the options need to be readily available for folks.
Thank you. So I don't know if anybody else. Okay. So there's a question about other states beyond New York. Are there plans in other abortion-friendly states to expand services? Are any of you in dialogue with folks in those states? Anyone? Yeah.
Start off, because I meant to say this when I was speaking, and then I got carried away, and I forgot. But this is incredibly important to mention that. So in New York, Catherine did say that we're building capacity around our abortion provisions, and we're headed in the right direction. On the ground at my health centers, we are overhiring, training up our doctors to expand their gestational age, changing clinical protocols while maintaining safety and staying in line with evidence, but altering protocols even the slightest bit to promote access. I mean, we've done so much in just the past few weeks as we gear up. I mean, I'm interviewing folks every single day to hire and to really overhire again, because we never want to have a shortage of providers. We want to be able to provide abortion every day of the week, 6 days of the week, so that our doors can always be open. So we're working very hard as we speak to make sure that happens.
Great, thank you.
And Terry, I would just add, sort of on the ecosystem level to what Dr. Shaw is talking about, please know that the provider ecosystem has been working for years now preparing for this possibility. So as far as what we're calling haven states and referral states, where patients may have to leave from and go to, there is this large collection of organizations planning for that possibility. So, obviously we would all be really irresponsible if we weren't doing that. So know that it's happening on the provider level, at the local level, and it's also happening at the ecosystem level.
Great, thank you. There's a question about in conservative states that are planning to ban abortion after Roe, do you anticipate further bans and restrictions to reproductive health care, birth control, sex education? I can guess the answer, but does anybody want to take that on?
Well, being I live here, I'm sure to say, yeah, I mean, the short answer is yes. And a lot of those things are already restricted to begin with. We don't have access to comprehensive sex ed. We're fighting about birth control access and those things already. So yeah, I mean, I think when and if they get this win, they're going to be looking for others.
So there's a question about a movement to organize housing, hospitality outside Metro New York for those traveling to New York for abortion. Is there organizing happening? I assume there will be if there isn't. But Catherine?
Sure. I mean, I think would love to flag the work of Brigitte, which is an organization that specifically is a fund for logistical care. So they look to travel and housing and staying and things like that. And their website is really great and people should check it out. And if you're looking for an organization to support, they do a lot of really great work.
Great, thank you. I want to go back, we only have a few minutes left. I wanted to go back to what folks can do. You said very clearly, donate to abortion funds. Are there other things that it seems to me there's so many levels of work to be done. So maybe we can just discuss for a moment other things that people can do in this kind of dire moment.
I mean, I would just like to say, and I emphasize this in my comments, that it's so important that your representatives hear from you, that your representatives hear that this is an issue that's important to you. Here in New York, you know, we have some hesitancy in some corners because people are not always so loud about this issue. And so even though the polling is on our side here, even though legislators are supportive, sometimes they need that kind of motivation. And if you need to know when to contact your legislators, certainly signing up for our e-alerts around reproductive health rights and justice. NYCLU has an e-alert on our website right now about some of the issues that Gabby and I spoke to with respect to bills in the legislature, and I would encourage everyone to send those messages in to their representatives.
Great. There's just before someone else jumps in, there's a question about how do we go to the offense? Can we change the narrative? It's possible to get medication abortion pills over the counter overseas. So any comments on kind of shifting the narrative and moving to the offense, given how outrageous some of what is going on is, given how women, children, pregnant people are treated in these states?
Terry, I wanted to jump in also in relation to what Catherine was talking about. I think the action item and the switch here is about addressing the shame and stigma that we have to admit that we've been complicit in creating and addressing that head on, because only 36% of people in this country believe that this actually could happen. Only 36%. The majority of people think this isn't even real. So we have a lot of work to do. And I believe that we're here because we've been allowing this shame and stigma around this portion of healthcare to be created and about our bodies in general. So I really feel like the individual level storytelling work has to happen for us to shift the narrative.
Thank you. Brigitte? You look like you want to say something.
Yeah, I mean, I think that this is, going back to all the tools in the toolbox and thinking really boldly. I mean, I think the Women's Health Protection Act is, a start of that. And I think that we can even go next level, and we should be thinking about state constitutional amendments and the federal constitutional amendment, and really thinking into someone else's question about how do we enshrine the constitutional right to abortion or the right to abortion, so that we're not constantly in this battle of the chipping away. And I think it's all of these pieces. It's eliminating the shame and stigma, ensuring that people have access, and just making it part of healthcare. This should be just a part of, of healthcare, and we need to make sure, obviously, to fix all the other aspects of our healthcare system too. And so it's all part and parcel to all the other fights that we're doing as well.
Great. Last word on this from anyone else before I turn it back to Donna? Dr. Shah, anything?
I think the issue around, I love, Stacey, that you brought up storytelling, because that's a large part of the way in which I advocate in writing, when I'm lobbying, because I know firsthand, just from sharing stories about caring for people from my own community who are Gujarati speaking, of South Asian descent, I've changed the way my family, my parents specifically, feel about abortion, because I come from a very conservative culture. I was born and raised in South Carolina. And going into sexual reproductive health care was almost like blasphemous. But through storytelling, I was able to really turn my mother into a little activist. Because it became obvious to her that, her people needed abortions, and that her people get pregnant and don't want to stay pregnant. And so I'm a true believer in storytelling and changing the narrative. I just want to point that out.
Thank you. Just before I turn to Donna, I want to just point out, of course, we saw Argentina, we saw the Green Wave, we saw Colombia. I was in Ireland listening to people actually really using storytelling, eliciting stories from people that brought out the connections between bodily autonomy, economic justice, all of it. So in really dire circumstances, we've seen things change around the world, and grassroots activism was central to all of that change, in addition to all of the litigation and policy advocacy. So I think there's no reason to lose hope, only to get more energized in this moment. So with that, I'll turn it back to Donna to close us out. Thank you all.
Thanks so much, Terry. And thank you, every one of the panelists, Stacey, Mira, Gabby, Brigitte, and Catherine, for an illuminating and hopeful, I think, conversation. Thanks, everybody who came to hear the panel today and submitted questions. Thanks to our sponsors again. We're going to be sending you all a survey to give us feedback on this event, and we hope you'll share with us honestly. And I just want to reiterate before I let you go, two things. Happy International Women's Day, and you can celebrate by signing up for our mailing list and telling 2 of your friends, okay, 5 of your friends, to join the NYCLU mailing list, get our updates, and find out when we need to hear your voice on critical issues around reproductive justice, and support the Planned Parenthoods and the other reproductive justice advocates around the country. Now is the time that we really can't afford not to be silent and not to be activists the way we're supposed to be. So thank you, everybody. Happy International Women's Day, and we'll see you around the block.